Thank you, Fabienne, and thanks to Harry and Adam for the kind invitation to be here. It's missed Toronto, but it's nice to be in Boston and closer to the meeting. So I'm going to switch gears now and talk about balancing response and adverse events in immunotherapy, so moving from the antivirals to the immunotherapies. So here are my disclosures. And so what I'll briefly talk about are the types of immunotherapy, and then thinking about what are the expected responses we might see, the expected toxicity, and then sort of how we might try to get this balance correct. So you can really think about immunotherapy in two very broad categories of kind of generalized immunotherapy versus targeted immunotherapy. And what I mean by this, on the generalized side, you've got the idea that you can sort of stimulate innate immunity, or you can broadly stimulate adaptive immunity, and here the best example would be checkpoint inhibition, where it's a fairly broad approach. And on the flip side, you've got more targeted immunotherapies, which are really focused on the virus and how it's interacting directly with the immune system. And here, the paradigm, of course, would be therapeutic vaccines, but there are a few others approaches, modified monoclonal antibodies with the so-called vaccinal effect, or also genetically modifying T cells, particularly to target them directly at the virus. And so there are differences between these approaches. And then there's also the sort of somewhere in the middle, which would be a generalized approach but directed to the liver. And probably the best example, which we're going to hear more about later today, would be targeting liver-targeted anti-PD-L1, so that you're really taking a generalized approach but focusing it in the organ of interest. Now, here when you think about these, on the generalized side, the real risk is that there's a risk of both local and generalized toxicity, and that's obviously what keeps us up at night when we think about immunotherapy, whereas probably the main risk of targeted immunotherapies is mostly a lack of efficacy. Of course, there's the possibility for unexpected events, but at least in terms of the immunological side of it, it's probably mostly just that they don't work, which isn't really a big deal. So if we think about expected responses, well, what we're hoping to do with any immunotherapy in a very broad sense is immunoactivation leading to surface antigen decline or clearance, and probably what that looks like, we think, is some degree of ALT elevation or flare, possibly with some amount of systemic immune activation, but again, this is the part that's harder to quantify or explain and probably makes us a bit more nervous. But I think what the point I would make about the responses is it's really critically important to determine that the responses that you think you're seeing are actually what you're seeing. So this sort of notion that seeing an ALT flare means that you're getting immune activation is really inadequate, and I would say in a way that's been a problem in the field so far, as there's been this kind of general comment about immune control or immune activation without really proving that that's what's happening, and that's given us challenge to really distinguish between response and potential toxicity. On the toxicity side, there's the general toxicities, where I think if we think about immunotherapy, ALT elevation's likely to occur with most, if not all, agents. And then we have to think about the agent-specific toxicities, both the predictable ones and, more concerningly, the less predictable ones. So ALT flares are kind of a special problem in Hep B. We have to really think about how to manage these, because on the one side, we have the so-called therapeutic or good flare, where we're actually getting what we want to happen. But of course, ALT flares can either be drug-induced liver injury or a very specific, more concerning feature in this context of immune-mediated hepatitis. So on the therapeutic side, you're looking to see viral control. If they're not on a nuke, suppression of HBV DNA, you're hoping to see reduction in antigens, if not clearance. It's usually self-limited, but it's important to recognize that even so-called good flares can be pretty severe flares, and so they can be potentially dangerous. And so that's what we want to see, as long as it's not too severe. But of course, the other challenge here is it may not happen on the therapy, it may happen after the therapy. And the good thing is at least maybe nuke rescue might help in this setting. When we truly see DILI, this is sort of an idiosyncratic or potentially dose-dependent injury. Most of the mechanisms here are unknown. I think this is less of a concern with generally the immunotherapies than the direct antivirals, but it's challenging to interpret, and it's important not to just assume ALT flares are good, because they could be bad. It's harder to apply Hy's law in this setting, and unfortunately we generally don't have very good therapies here. The immune-mediated hepatitis is primarily focused on the checkpoint inhibition, where we've learned more about this from the cancer setting. The concern is that it can be very severe, and it's a bit hard to predict, as I'll show you, but at least fortunately, so far, it's relatively responsive to immunosuppression. So I think the real challenge here is right now we don't have very good biomarkers to distinguish these, so we're sort of looking at ALT flares in any context and trying to interpret one versus the other, and I'm going to make the case at the end that we really need to dig down into this to understand what's actually going on to better understand this situation. So let's think about the agent-specific toxicities. We talk about interferon as our first immunomodulatory therapy, which is gaining some traction again, and of course we're very familiar with all the side effects. It's important to recognize that most of them are not treatment limiting, and the strategies that are being considered to use interferon in the context of HBV cure strategies are to shorten the dose. There was the hope for the better tolerated interferons. I think it's disappointing to see that lambda, really at least in the delta setting, is stopped its use, and that probably is going to limit its use for looking at it for hep B as well. And that's there's not really a lot of other exploration right now of better tolerated interferons. So I think the challenge with interferon, and I don't think we should underestimate this, is if we come up with complicated regimens that require interferon, fine as a stepping stone, but if that's our end game, I think it's going to be very challenging because it may be harder to convince providers to use this, even if patients are willing to take it. So what about moving on the innate side? Well, the toll-like receptors, I would sort of describe the toxicity profile that's expected to be kind of like interferon light, where you're going to get local production of interferon, hopefully with reduced systemic activation and side effects, but it's possible, and we got a hint of this from the TLR7 data, that getting adequate targeting engagement for efficacy will be associated with the same toxicity, or at least side effect profile you see from interferon. So it may not be less toxic than interferon. And I think the other challenge here is TLRs clearly are only going to be used as part of combination therapy, and that's one of the challenging things for teasing apart both efficacy and toxicity, because although it may not be a major driver of toxicity, it's going to be hard to tease apart what role they're actually playing. And of course, we have a reminder on the about the dangers of things that we don't expect. And everyone was sort of excited about this potential novel mode of action with this RIG-I agonist until it really looked promising, until it didn't. And I would really highlight that the toxicity seemed to be duration related, but it wasn't obvious until it was obvious. I mean, that sounds silly to say, except that it wasn't really easily predictable, even with the animal studies that had been done. And I think one thing that it makes the case for is to have longer non-human primate studies to understand sort of longer duration effects of immunotherapies, because we don't always know how they're driving this. And it's also important, even when a drug is dead, to dig deeply into the mechanism so that you don't make the same mistake twice, which has probably happened in drug development in a lot of settings. So now we come to checkpoint inhibitor therapy, and we move to the sort of generalized approach. And here is certainly a lot of interest, but there's also a lot of consternation about using this very generalized approach, because what's acceptable in metastatic cancer might be less acceptable in the setting of well-controlled HBV. And I highlight that with both PD-1 or PD-L1 therapy and CTLA-4 therapy, lots of different itises that can occur, so lots of different autoimmune conditions that occur, but also a mortality that is well recognized in the cancer field from some of these toxicities has been recognized. So can we do a little better at trying to tease this apart and find the sweet spot for using these agents? And so there has been starting, and I would say it's been a little slow in the cancer field. Most of the excitement is focused on the response, but there's now been some interest in trying to reduce these immune-related adverse events and understand their mechanism. Most of the mechanism is thought to be related to T cells, because that's really primarily where they're working, and the sense is that there's increased priming and activation of antigen-specific T cells, but also expansion and activation of, interestingly, there's pretty good evidence now in the cancer field of pre-existing tissue-resident memory T cells, so that these were actually already there, and you're stimulating these to emerge and lead to the toxicity, and also potentially a role for blocking Treg activity as well. Interestingly, although not directly the target, there does seem to be a role for B cells here. There's pre-existing autoantibodies, especially the tissue-specific autoantibodies, are associated with with a higher risk of immune-related adverse events. And as you follow patients, and this has been done again in the cancer field, you see emergence and the change in the autoantibody profile that is associated with a higher chance of developing these IRAEs. And then also, sort of more learning from the therapeutic side of this is that targeting anti-cytokine therapy, particularly with colitis, with anti-TNF therapy and anti-IL-6 therapy as well, suggests that another mechanism might just be release of cytokines. But one of the challenges for this whole field is that in cancer, it's very clear that immune-related adverse events are associated with better response and actually better clinical response on the cancer front and overall actually improved survival. So that's a challenge for us because we don't want to see immune-related adverse events, but if that is really the biomarker for efficacy, then it's really a tight balancing act for us. So how can you try to minimize toxicity from this? Well, first is the choice of agent, and there's clear from the cancer literature that CTLA-4 has a higher risk of immune-related adverse events than PD-1 or PD-L1. There are other immune checkpoints that are being explored in cancer, and whether they'll be as relevant in the virus setting is less clear, but they likely have a lower risk. Importantly, dose is not that important. It is for CTLA-4, but the cancer literature are pretty clear that that the toxicity is not dose-related for PD-1, and I think we need to remember that. PD-L1, it's less clear, but PD-1, there's really no good evidence that it's dose-related. There is some data from the cancer literature that organ or tumor-specific activity is relevant, and we're going to hear more about this with the liver targeting PD-L1 later today, but there are promising data in oncology where you can take the PD-1 engagement site, cover it by a peptide that's cleaved in the tumor microenvironment, and significantly reduce toxicity. So I think this does give us promise that targeting it to the liver may be more effective. And then there's also the potential to try to choose our patients well. So clearly pre-existing autoimmune disease, it kind of makes sense. It's variable, but there is higher risk and more severity with pre-existing disease. Pre-existing autoantibodies, overall a higher risk. It's greatest with the tissue-specific antibodies, and then as I mentioned, there's emergence and changes of the antibodies, so you can follow them over time. And interestingly, in the cancer literature, there are now some nice panels where they're looking at presence of antibodies prior to therapy to predict immune-related adverse events, and I think we would be wise to try to use these, especially in a setting where we're really trying to minimize toxicity. People are looking for genetic associations, none found so far, and some interesting data about the microbiome. Again, some species that are protective and some are associated with risk, clearly still in its infancy. But there's also the possibility that some T-cell populations that emerge after dosing, so could you identify these after dosing someone to predict toxicity and potentially prevent it? I think these are all things to explore, and fortunately a huge literature in cancer that we can learn from. So I think the other challenge for us in this whole field is the things that we don't expect. And we learned this from the COVID-19 experience with the vaccines, that rare unexpected toxicity is very hard to predict. It's also very easy to miss in clinical trials. We are not going to have the experience of dosing tens of millions of people like they did with these vaccines to identify these pretty early, and that's always a bit nerve-wracking for us. Additional challenges are that we're going to combine therapies. So then you have to mix in dose timing and sequencing. So if you take the sort of classic paradigm of an siRNA and anti-PD-1 and a therapeutic vaccine, you might think about doing this, a few doses of siRNA and anti-PD-1 and then followed by the therapeutic vaccine. But first you got to figure out the dose, which goes first and for how long. If it doesn't work, is it the agents or the way they were combined, or are they used in the wrong population or the wrong individual? And that's very confusing and makes clinical trial design, especially with small numbers, difficult. And then, of course, the population is challenging, which are going to maximize efficacy and minimize toxicity. And ideally, you'd have biomarkers, but that's not always easy. Of course, then we have to think about the actual population you study, cirrhosis, people who need it the most but are the most dangerous for using immunotherapy, and these other groups who may be a little less likely to at least be studied initially. So can we predict response? Well, we have some very simple approach of using anti-HBC, the titer for this, as being a marker of immune activation. And at least with interferon, you can see that patients that get that had higher titers had a higher probability of S loss with interferon. It's modest, but it sort of gives you the sense that if you can identify patients with greater immune activation, you might be able to predict response. But I would say we should do this more precisely, and these are data from some nice work that one of Adam's PhD students worked on to develop a three-color fluorospot assay to be able to look at peripheral responses to the virus in real time. So you can take this, look pretty quickly to see whether you're seeing immune responses targeted at the virus. And this can be useful, and this is just an example where if you look for checkpoint inhibitors, you can take these are ex vivo, but you can take in patients with different phases of Hep B, and you can give them anti-PD-1, their PBMCs, and then see whether their response to viral antigens improves. And you can see both here with interferon gamma, and interestingly in this study suggests that actually IL-2 responses are probably more relevant. But this is helpful for a few things. First of all, you can see from these data, which are not, we don't know if this is actually predictive of response, but you can see that actually the patients in the inactive carriers or immune control phase, they might not be the group we want to give a therapy like this, but at least from these data, it looks like they're the ones most likely to respond. It's important to know that, so we don't go into the wrong population. For example, the e antigen positive IA group, which seems to have the least response, at least in this type of assay. And at least this concept is potentially useful for not only figuring out which group to study, but also potentially for individual patient prediction. Of course, this needs validation, but I think the concept is attractive for choosing immunotherapies. And finally, we have a lot of excitement about the idea of not just using the blood, but the liver. And I would just highlight this paper that came out in the Journal of Hepatology just this month, which is really a consortium across a number of groups looking at fine needle aspirates and their ability to be able to use these to really look at what's going on inside the liver. And I highlight the number of authors here because this really was a group effort. Adam sort of orchestrated it all, but a lot of different PIs involved to get this done. But it's useful and really shows that you can get good data, which really show differences between the blood and FNAs. I'm just showing them here for CD8 T cells, but there are in different cell populations that you can see differences, and that they may be predictive of both the what's going to happen, but also to really understand the mechanism of action, particularly for immunotherapies, and using these in earlier phase 2 trials to really know that what you think is happening is actually happening is really quite important. So to summarize, immunotherapies are exciting, but they're also a bit scary. Adam always says they're not, but I think they are. So targeted therapies are preferred. The major risk is really lack of effect. The generalized immunotherapies, I think, are a little bit riskier, but maybe we can try to predict response, and we'll be able to identify the population and even at the patient level to be able to make these a little bit safer. But of course, that there are still added complexities of the combinations, the dosing, sequencing, timing, etc. So it's clearly a tricky balancing act, but I think we are slowly getting the tools to make this a safer and more promising approach to add to our HBV cure strategies. Thank you very much.